I think, you see, for low-income countries, is by far better for them economically to invest in primary care. It's about the unit cost, where about 80% of the entire health and public health issues could be addressed at the primary care level, rather than a much higher unit cost that these cases of simple tonsillitis or indeed vaccination or whatever, referred to a hospital where the unit cost is very high and resources are very limited. And unless they realized that actually then the real investment should be in areas of a low unit cost with a high return. And that is the case for primary care. The problem in low-income countries, most of them living or their health system is based on international assistance. And unfortunately, the money which is coming through international aids is actually very much earmarked for specific things. And that is what's creating a problem within the health system. For example, a lot of money could come from Gates Foundation, and this money tend to be for HIV program. It's fantastic, but that affecting the rest of the health system. And I don't know, many times, even in our writing, we suggested that international aid should be for the totality of the health system and investment in areas of low cost, high return. And I really see no other way forward for low-income countries but to move in that direction. Primary care is the way for universal health coverage in these countries.
Absolutely. And I mean, I think what we've been already alluding to, the issue of team-based care, I mean, that is, I think for every country, but particularly for low and middle income countries, recognizing we will never have sufficient doctors, actually. And we actually don't need, I mean, we've got, someone already mentioned, I mean, the physician assistants, physician associates, clinical officers, that cadre together with the community health worker can provide, as we've seen in many countries, a very effective primary health care, so that doctors are utilized for what they are best at doing, which is in terms of clinical reasoning around complex medical problems, and supporting the team, training, providing support, helping with management, etc. And that is certainly the way to go, and the way that has been shown to be effective in many places. So, I mean, we have this experiment that was started in South Africa in the 1940s with developing community health centers, a community-oriented primary care approach, which was very much around that, adopting a whole community, having an area that one is responsible for, and seeking health promotion, prevention, all elements of primary health care around that. Unfortunately, that was supposed to be spread across the whole country. Apartheid brought that to an end, and it was exported to other countries elsewhere around the world. But I think that is still the model that we are trying to return to, and that is an effective way of providing primary care.
I agree.
Maybe more on this interesting topic of team-based primary healthcare. What do you think, what should happen in this topic, or are there some countries in your mind which you see as a role model where other countries could learn from? You mentioned community-oriented primary care in South Africa, of course.
I mean, we already mentioned two countries, but I think generally speaking, and I will be very controversial here, I don't mind to be to be very honest with you, that many countries, they have a primary care by name, but not by function. And rarely policymakers realize that what they have, it's simply an extension of a hospital, like an outpatient, because the 5 essential elements of primary care does not exist. For example, the full registration of the population, the issues of gatekeeping function, the issues of the really the full access for all type of health needs, whether it's preventive public health and curative things, and the issues of being holistic in nature, and the last but certainly not least, provided by trained family physicians with their team, as described by Ian. And that team could be even extended more and more in bigger cities, you know. That does not exist. These models are not exist in many countries around the world. All what they have, people accessing services when they feel ill, you know. Public health is not fully integrated within primary care function. There is no national systematic approach to prevent diseases such as national screening program, call and recall system, national vaccination program, national health check program at different age group. And all what we see actually in these countries, because of population growth, because of changing in the pattern of diseases, and because of aging population, that more and more they are becoming curative disease model primary care center. This is not primary care. And this is not the way we would like to see primary care developed in many countries around the world. You see, the problem is policymakers don't realize that. All what they look at, they have centers, they have doctors. The majority of them are not trained in primary care, i.e. not family physicians. The vast majority, I visited many countries around the world. All the doctors are there actually graduate, newly graduate. They take them from medical school to primary care center and they say, we are providing services. In reality, they are not providing any services which I can't describe as primary care.
I mean, I can tell you what typically happens in South Africa, where we have compulsory community service for doctors, is that who are the doctors that visit the clinics? It's those people newly graduated, just as Salman said, if we're there for 1 year, they get sent out and the senior doctors stay in the hospital. And it should be completely the other way around. The senior doctors are the people who should be going out, and the community service doctors who've been trained in a hospital complex should stay in the hospital. And yeah.
I mean, Ian, we need to emphasize on this, because this is what Barbara Starfield, painstaking research, was focusing on, i.e. the definition of primary care. And I'm very honored and privileged that one of the author of she was with me as well, late Barbara. In 2008, the primary care now more than ever. And we were very clear, if you go to the WHO World Health Report 2008, we were very clear that the primary care should have these specific characteristics, especially the registration of the people, you know, in that community, in that geographical area, in that catchment area, depending which country you are. You define that population, and that primary care center or services really directed to that community, because they are registered. My primary care center, all of us as a primary care team, doctors, nurses, etc., we know our population well. You know, we almost conducting indirect need assessment, because from the frequency they are contacting us, from the way we are calling them, from the way we are interact with them, there will be much more actually specific community intervention than simply being an outpatient clinic, an extension of a hospital.
Thank you very much. I want to include also some messages from the chat. There, for example, Karen was agreeing with the topic of community health workers, that they are especially important in rural areas. What is your take on community healthcare workers within the primary healthcare workforce? And do you see examples of countries which implemented community health workers really well?
Hey, and you started in Africa. So
well, yeah, but I mean, I think one of the the examples that Salman mentioned earlier is Brazil, where they have been very effective in terms of their family health system that they developed, which is family physicians. And in fact, even that process was fascinating because they didn't have enough, and they had the biggest training system for family physicians around the world. I mean, they trained people in their sites all over the country in terms of retraining them, because they had people who weren't from a primary care background that they put into the, anyway, that's the side. The family physicians working with nurses and community health workers. And exactly as someone was describing, that the community health workers are linked to a geographical area, and they are the bridge between the clinic and the healthcare team in the clinic and the community. And they're very much geographically focused, and they can bring the problems of the community as well as doing health promotion, prevention, and they're linked to a broader team that works alongside the community health center. So for every few teams, you will have a broader group of capacity that you can bring in. Iran is another good example where they've used the community health workers, their village health workers, very effectively in terms of making a difference. I was privileged to work in a rural hospital in South Africa on the border of Mozambique, where we had some of the earliest community health workers in this country. And we couldn't have worked the way we did, especially in the early days where we had very few doctors and even very few registered nurses. We couldn't have worked the way we did without this network of community health workers who were integrated with the community, linked to the community leaders. And, you know, anything that we needed to do, we consulted with them. They brought issues to us, and it really created that combined public health and primary care approach in terms of dealing with the community that we were working in.
I fully agree. And the two additional examples, in addition to South Africa, we can bring is actually Brazil and Iran. Brazil, I actually involved in the development of the primary care system, which started from scratch. And Iran, we did a major review of the rural areas services. But let us take Brazil. Brazil, the system designed in a beautiful way that actually the primary care services is complemented by excellent services. They are part of the team by community health worker. And each community health worker attached to primary care center, given a workload of 140 families. And these are defined areas, as mentioned by Ian. You know, they provide excellent public health services because they visit people at home, they look at the way they are living, they look at the way they are behaving in terms of health behaviors, etc. Those who need support from physicians and other primary care staff, they bring them to the center themselves, because sometimes the access to the service, inability to travel, you know, lack of resources to travel. We shouldn't really underestimate these sort of small barriers, but make a lot of big things to families with low income, and especially in rural areas. You know, in Iran, they have the health house, which is a small post in villages run by community health workers, and these are attached to primary care centers. They do exactly the same. They do provide advice, public health advice, sometimes some of them, those who are well-trained, vaccination, etc. You know, but the important element of that, they are from the same population they serve. So they do understand the population, they do understand the language. By the way, there are language differences between one community and another, you know. They know the culture, and they deal with them, and they have the trust of the community, you know. And it's a two-way system. They feed into the primary care center, and the primary care center can go to them at any time when extra help is needed from senior colleagues who are fully trained to be there serving the community. A lot of publication on that, by the way. My good colleagues Matt Harris, he got experience of that in Brazil, and he published a few papers on that. The Iranian published a few papers, and it's worth looking at that. This is which question? Okay. The productivity, yes, there is a big issue about productivity, and you cannot blame health workers when productivity is poor. The blame is very much on management, the blame on the way the system is developed. You know, if you have primary care centers, which is, you create a center and you leave it like as we describe, as an outpatient clinic. So people, they go there when they need it. And if there is no strong trust between a primary care team and the population will bypass them. They go to the hospital, they go to private clinics, etc. When you have a system which is nobody can, except an emergency, can actually bypass primary care, whatever the money he or she got, you know, if you have that gatekeeping function, then everyone will go to primary care, even just for referral. But gradually they discover, at the beginning, it is just a letter of referral. But gradually, which I've seen it, by the way, in many countries, gradually they discover that the system could serve them cheaper, more effective, and much more better, because it is undifferentiated approach, it is holistic approach, you know? And this is about the system one is developed, educating the people on how to access health services. And I don't think really we should put any blame on the low productivity of health workers. Nobody I'm aware want to be poorly productive. No one. All of us want to serve, all of us want to work hard, etc. But it's about the system.
And about training people to work in the system. I mean, if people are not properly trained, they're not going to know how to function in that environment. Yeah. There's a classic example that always sits in my mind when I visited a rural hospital, and there were two young therapists there, an occupational therapist and a physiotherapist, sitting in a pristine, clean rehab center with not a single patient in sight. And I asked them what they were doing. They said they were waiting for patients.
Yeah.
But there was a whole community outside the doors of that hospital desperately in need. And it's not their fault. They were not trained at university to go out into the community. They were trained that patients would come to them. And that's a similar thing that we deal with. The other thing is that people have to be supported, as I think someone implied. But what we have often in our situation, and in many countries in Africa, there's just no supply of pharmaceuticals and just basic drugs, bandages, the basic things that they need to function, and becomes demoralizing if you don't have that kind of support and that system, the management that Salman referred to.
Hello, thank you, Florian. So I'm from Slovenia. It's a European country, and I really can only confirm what has been said till now. In Slovenia, we have a very strong primary care from 1927, 100 years old, and the specificity is that it is stemming from public health. So for me, the key characteristics that are really important are, of course, empanelment and the gatekeeping system, because this allows primary care physicians to conduct also the public health functions of primary care, which is prevention and early detection of disease. This being said, I've seen in many low-income countries that patients do not have trust for primary care. And this is, of course, a problem. So another very important thing is that primary care physicians need training, need good education, but they also need to be empowered to offer services that will be of value to patients. If they only visit primary care and then they're referred also to the hospital, of course they go directly to the hospital. So the country needs to make sure that patients get their needs covered by primary care physicians, which includes giving primary care physicians more authority to deliver more services, to be able to prescribe drugs that are reimbursed so that patients do not need to visit a hospital physicians for that. And to address the issue about how to make primary care more attractive for physicians. Of course, in Slovenia, we also have this issue. And what we are discovering now is that young physicians, they really want to do what they know to do. And our family medicine specialists with 4 years specialization after graduating in medicine, they know a lot and they want to do what they know. So we are considering shifting more services from hospitals to primary care, including ultrasound, including some smaller interventions, so they can really show what they can do. And this way, we are being a little bit more successful to ensure that more young doctors would choose primary care as their workplace in the future. Thank you. Over.
You may have a long history in the old Yugoslavia of strong primary care. You're absolutely right. But this is after the breakdown of Yugoslavia into many countries. Some of it started to disappear, like Serbia, Croatia, etc. If you take this, the big states, you know. But having said that, you know, unless you have a primary care based on gatekeeping function, i.e. nobody bypass it. And I'm surprised that you said primary care doctors cannot prescribe, because if you take the UK model example and many other European model, all the prescription happening in primary care setting, very few drugs are restricted to hospital setting, very, very few indeed. And even these, when patients are discharged, it's in the hand of their primary care doctor. It's my doctor, because at the end of the day, he or she is the only person who have the full picture about me. Because a hospital visit, whether it is a consultation, this is where the name consultant came from, whether it's a consultation or indeed surgical intervention, it's like a kiss visit, you know. The patient is not known in that place, you know, just for that visit or that intervention, and the relationship ends. While in primary care, the relationship is continuous and within the whole family, within the whole community context. So unless you have that really important element of gatekeeping function, you will continue with the large percentage of dissatisfaction that actually highly trained people are not able to prescribe, not able to deal with about 80% of all disease burden and public health, you know, as we mentioned earlier.
Yes, just to explain, this was the practices I've seen in some countries in Central Asia, that they don't have authority to prescribe reimbursed drugs or perform even diagnostic procedures. Yeah.
It's rubbish, you know, because the hospital should serve primary care. I, as a primary care doctor, you know, I know what the needs of my patients. I can order any investigation I want, you know, before even I decide whether that patient should be referred or not, you know, and that how the approach should be. I mean, people collectively, family physicians, and actually Slovenia could come together and saying, look, the way forward is for us to be fully functional. And fully functional, I'll take you back to Barbara Starfield, I'll take you back to WHO report 2008 on primary care. It's about really the full function of primary care.
Yeah, thank you very much. There's another comment from Sunanda from Botswana, please.
Yeah, thank you very much. I just wanted to emphasize this issue about looking at a functional health system rather than looking at whether it should be doctor-based or whether it should be community health worker-based, even to some extent whether it's, urban, rural. You have to have the whole system supporting the concept of the district hospital or the district health system being the center of the health system, rather than what happens in many countries, which is that it's what happens in the big cities, the capital cities, and everything else is talked about as the periphery. Because until we get that status for primary healthcare and for district healthcare, it'll always be treated as a second-rate service. And the finances follow that issue of the status. So people coming into towns or cities to get healthcare, bypassing the hospital that may provide a perfectly good service, but there's an assumption that if you pay for it, it's better, or if it's in the city, it's better. So that's the first thing, is that there has to be a national movement towards providing a health system that is supportive of the whole population. And the second thing is the issue about the teams, that if you don't have well-supported teams, it's very difficult for individuals sitting in a primary care clinic to try and provide a service. The issue about teams extends to the extent that it's best articulated, in my view, in the community-oriented primary care, because it's public health plus family medicine plus primary health care. Because if you take the issue of surgery, I think somebody put access to surgery in the chat. The issue of surgery, if you look in most African countries, the main surgery that's done in the public sector is cesarean sections. So does that mean that other people don't need surgery? It doesn't. It means that there's a huge amount of unmet need in communities where people are not going to the hospitals to have surgery because either they don't trust the service or they don't know that this can be resolved. A lot of people with huge growths, huge tumors, abdominal hernias, etc., carry on living with them because they think that there's nothing that can be done about it, because there isn't a public health approach of going out into the community to do needs assessments and to educate the public on what they can get treated. So I think, until we address this in a systemic way and address all these aspects, but in particular having this really coordinated and focused approach, it's very difficult with fragmentation of the health service. You have a few projects which are good here and there, but they're never scaled up because they don't get the resources, and it continues like this, and people get worn out and demoralized and then leave to go to places where they're better valued. Thanks.
I think, thank you very much, if Ian allow me. You touched on many issues. I mean, first of all, in terms of primary care, must be the first contact with the health services except in emergency. And indeed, even some primary care centers could provide minor injuries unit or something like that. Number two, the issues of system integration is not only vital, but it is step one in achieving universal health coverage for anyone who is planning to achieve universal health coverage, as the SDG 3.8, very clearly specify. And it's unfortunately, the whole concept of universal health coverage is misunderstood. People really, they talk about universal health coverage, and it may be a topic for us here. But frankly speaking, they don't know what is it about. It is, the universal health coverage is about two important elements: that full access to services according to my need as a citizen, as individual. And secondly, which is vital, that system, an integrated system, meeting my health needs, whether it's a preventive or curative, rehabilitation, whatever, must be providing financial protection. And financial protection here, everyone would like to define it in the way they look at it from their narrow angle, which is health system, rather than the global reality is that actually that financial protection should, for me, I should receive the services at the time of delivery free or very little cost, i.e. I prepay for it, according to my ability. and unless we have these two ingredients in any health system, you will see fragmentation will continue and the people will suffer, and the financial catastrophe, which many people facing because of major health issue or health incident happening in that family. And you need to remember my last word about this, that 2% of the world population go into catastrophic event because a health crisis happening within the family.
Yeah, I want to pick up on that, and colleagues in South Africa have done some work in one of the rural areas around access to healthcare, and healthcare is free at the point of need in South Africa, but there are families which they have documented are spending up to 15% and even more of household income on accessing that free healthcare, because there isn't access near to them, and the transport and the other costs or the loss of income when they go to hospital, etc., becomes catastrophic. Anything over 15% is catastrophic. Above 10% is critical. And yet many families in rural areas in our country are experiencing that. So that issue, just to reinforce that, but also to pick up on what Sunanda was talking about in terms of unmet need. Yeah, just to re-emphasize that often health planners plan on the basis of the services that are provided and people accessing services. And yet there are many people with unmet needs. And until one goes out into the communities and actually has that structure, one cannot find and see the unmet need. In my situation I referred to earlier, working in a hospital where we were building clinics. People thought, oh, if you build clinics, we're going to have fewer patients coming to the hospital, outpatients. Well, we didn't. We had more patients because the clinics were discovering the unmet need out there. And actually, you have to reach a certain point where you actually start lowering the numbers coming to your hospitals. And until you've met that unmet need, you won't get to that point.
I mean, this is Ian, very important point about the unmet need, and thank you very much for reiterating it. I really strongly believe when you have comprehensive primary care, with 100% registration, you will be able to develop a system within the primary care setting that identify the people needs, although sometimes they are not aware of. For example, you have to identify all diabetic patients. You have to identify all those individuals with hypertension. By introduction of health check, regular health check, by introduction of screening program for specific diseases, specific risk factor, for actually sending information to patient if you are actually suffering from the symptom, this, etc., etc. So this is where I see that primary care is engaged in community welfare, But to continue with this system, which exists now around the world, which is simply an outpatient, I go on demand when I feel that I need it, This is not primary care. And I advise countries around the world, and I will stick my neck out and say, listen, stop, call it primary care, call it something else until you have a system of truly primary care with 100% registration of your population. I don't want this silly terminology misused. And I know that a lot of policymakers around the world misusing the beautiful term of primary care.
Yeah, thank you very much for this great discussion. And I would like to go back to the chat because there was a big discussion on the topic public versus private. So there were comments that in some countries, family doctors, part of them are private doctors, part of them are public doctors. And in other countries, it's like family doctors are private and other healthcare workers are public. What do you see? How do you interpret this issue? And how should we go on that we train healthcare workers with public money who become later on private providers?
I think this is one of the most difficult questions, but it is the easiest to answer. You know, this is precisely the question which I was asking, I think, 2009, 2008 in Malaysia, when we did a review of their primary care services, and it was split between private doctors providing primary care services and public doctors providing primary care from well-structured, well-built, nice health centers. And the answer to the Malaysian government at that time, it was very, very clear and very specific. Bring all those people under one umbrella. And they said, oh, no, primary care, private primary care doctors, they don't want to join. And actually, I met with them over dinner with many, many of them. And all of them said, we'll be delighted, at least if the government contract with us, you know, to be part of the services. At least we know that we have secure income. We have some security. We have a structure. We have an input which is matching the rest of the services, you know. And this is how it should be. Primary care, all services, primary care services, who provided that service is not the issue. In the UK, all primary care doctors are private, but they are under, you know, NHS umbrella. And they have contract with the NHS, you know. It doesn't make them outside the system, all right? It's simply the way they receive the money. And instead of salary, they receive money according to contracts, you know, and I don't want to go through this, is actually very complex. And there are a few doctors, you know, which is providing what is called primary care services privately outside the system, but they are not primary care doctors. They are simply non-specialists providing some sort of care in a private setting, mainly to people from outside the country. That's it, you know. Bring them all together under one umbrella. I go back to my earlier definition, unless you define the primary care as it is, as an integrated system, addressing the whole country, you know, who is providing the service within the system, privately or publicly, is not an issue at all. Bring them under one umbrella. I don't know what Ian feel.
I agree, absolutely. Yeah, I mean, we have this crazy situation in South Africa where we have, I mean, roughly 20% of the population is cared for by the private sector, who spends 80% of the total expenditure on health in our country. I mean, it's, you know, and yeah, until we're under the same umbrella, we're going to continue with that kind of disparity.
Yeah, thank you very much for this response. I go back to the chat where Karen is saying that we also left the category of countries, those countries where doctors work in the public clinic in the morning, go home, and do after-hour services on a private basis. Do you have any comment on this issue, or?
I mean, this is a vital point, and thank you very much, Karen, for raising it. Many countries now separating between public and private, you know, and I don't want to mention some of the countries, but part of the STP, which is the transformation plan in Turkey many years back, they did separate between public and private, despite the objection of the Turkish Medical Association. And they were very successful, actually, in improving the services in fantastic way. There are a lot of countries like Tunisia, et cetera, many countries around the world that is trying to separate between public and private. But to be very honest with you, for those who are actually in primary care, they should work within the services under one umbrella, you know, as I mentioned. And the laws should be very clear. Either you are in contract with the primary care services or you are out. You cannot combine this. For hospital care, this is totally different, you know, because majority of the people who are working in the private sector in hospital care, you know, they work in the public services for 2 or 3 days, and the rest of the days, we call them part-timer or maximum part-timer. And they spend some of their work actually in the private sector, which is no harm, because the example of the UK that I, as a GP, I can refer, you know, my patient anywhere. I could refer my patient to public hospitals, which is the majority go to the public hospital. The private sector is very, very small, is less than 8%. You know, I mean, I could also refer for certain cases a patient to a private hospital. I could refer, actually, I did allow when I was director of public health, some of the patients to refer outside the country because treatment were not available in the UK, but available in other European countries, which we funded there because the NHS is like an insurance. And the country should be like an insurance, big social insurance category. But that restriction should be there.
Yeah, thank you very much for your comment. And I would like to go back to another discussion we had the last days in our email list in the global forum, that we talked about the golden handcuff. We talked about it in the context of, should we pay doctors to work in the rural area, or should we even have laws that doctors have to pay in rural areas? And I guess we could also apply to the discussion on working in the public or the private sector. What is your issue? Because I know that some people prefer it and some people are against it.
I refer to Martin McKee's beautiful response in terms of doctors are intelligent. They don't need golden or silver handcuffs, you know. I think what Ian mentioned, and I did follow him very clearly, that if you have a good health system, if you have really well-defined primary care services, if you have good training, if you have good career opportunities, you know, you don't need these sort of incentives. You know, of course, doctors are not well paid all over the world. We have today our junior doctor striking for 4 days. This has really caused a huge problem within our health services because it's a very, very vital and important workforce. You know, we have, I mean, we call them junior doctor, but some of them are very, very senior, like last year senior registrar or something like that, you know. So to be honest with you, if we design a health system which is addressing the issues which we discussed, you know, rewarded well salaries to all doctors, whether hospital doctors and primary care doctors. And we need to remember also the shortages is not only in the primary care. We have a lot of shortages in many specialties in hospital care as well. So these should be addressed at the same time because a strong primary care depends on a good and strong secondary care because they are fully integrated and they work in harmony. There is no point in referring a patient to a hospital where there are no specialists in that field or the number of specialists are too small and it finishes in a very, very long waiting list and suffering, you know. So it's about a system, it's about a reward to everyone, you know. And I just want to finish with a statement. A plumber could take in Britain 70 quid or 80 quid an hour, while a junior doctor take 14 or 15 quid an hour, which is absolutely unfair. I will be a
Yeah.
plumber.
I mean, I'd agree with that. I mean, we have, I mentioned earlier, we have compulsory community service in South Africa. What that means is that we have, you know, every year you have new young doctors coming in to work in rural areas, and you have a shortage of the senior people to support them and train them and work with them. And actually, I mean, we know from international experience, if you train people right, if you select them right and so on, you'll have, not everybody by any means, we don't need everyone, but you'll have people who make that their life's, you know, what they want to do, because they feel comfortable, they feel prepared, they feel supported, and they can do that. I also like what, I mean, in terms of incentives, rather than direct financial incentives, I like what they've done in Iran, where you get points in order to specialize. If you want to enter into a specialty, and you get more points if you go and work in a rural area. So many doctors will go and work there for 2 or 3, 4 years, and then move in to specialize in, you know, into their chosen specialty. Yeah, so I mean, the biggest problem for me is actually the retention of people, so that you have more senior people in rural areas, and not the short-term recruitment.
Yeah, then I would ask my own question. We were talking today about this huge topic of workforce, and it seems we have 100 problems and probably 1,000 solutions for this topic. What do you think? What is the most important problem, and what would maybe be the most important solution? Or if you would have one preference and one thing to choose, what would you go for?
I think I will go for standard. I would like to encourage WHO and countries to set a standard for the number of doctors needed in different specialties. We are facing a challenging time in health and healthcare delivery, and that is actually advances are so fast, so rapid. We will see that some of the specialties will disappear. We will see that some of the new specialties emerging. Technology is there and advancing in fantastic speed. So the cornerstone, the backbone of any health system is primary care. And as I mentioned, is the unit cost. We need to be there, and we need to be specific in terms of standard needed, the number needed at primary care services to be that successful. And again, in hospital care, we need to define what standard is needed in terms of the number of doctors. You see, in many countries I visit around the world, you know, they have a single specialty in a hospital, single person, for example, one ENT surgeon, you know, that you cannot function in modern day. You need a critical mass of critical number of people working together as a team. And therefore, hospitals should not provide all type of services to serve primary care. You know, that hospital, they need to come together as well, you know, by merging services. I mean, ENT services could be provided in one locality, not necessarily in every locality. Same things with obstetric and gynecology. Definitely highly specialized services like cancer services should be based on hub and spoke model, that not every hospital should provide a treatment for cancer services, should be referred to a cancer center, same thing for cardiovascular, and same thing for neurosciences. So that will help to organize primary care effectively, and will be using the resources to respond to the need of the population which is served by primary care services.
Salman, WHO's health workforce team at headquarters has set 44.5 doctors per 100K population as their standard. I do agree that it is not granular enough to have specific standards for each individual specialty or even for primary care, but at least they're working on it.
Well, thank you very much. I'm aware of that, but I was talking about more specific details about the possibility of giving much more specific numbers by specialty, by primary care, etc.
Well, that would depend on the model of care that each country adopts. So if you have a model of care, such as in South Africa, where you have a lot of community health workers, you don't need as many doctors, but you need more community health workers, or lady health workers in Pakistan. I mean, it depends on your model of care for you to, you can't prescribe how many doctors without knowing how they're going to be employed or engaged or utilized.
I think this is the main issue, because as I said, each one defining primary care in the way they like, you know, and that is the risk. While when we have a standard, I as a country with low income, I said I cannot achieve that standard, but at least I can put it as an ambitious standard, something I will aim for, rather than saying, oh, this is designed for the Western countries. What exists in the West, everyone in the East or everyone in other countries in the South or the North deserve exactly the same services, if not better. That is my starting point.
So, Florian,
Yes, please.
to answer your question from my side, I mean, I fully agree with what Salman was saying, but I also would like to return to one of the things we said earlier, and that is we have to fundamentally change training. You know, and as long as we carry on training the same way, we're replicating the system. The Lancet Commission on Training Health Professionals for the 21st Century set out some wonderful ideals, but there have been small little changes here and there, but some of the big things they talked about hasn't happened. So, for example, they talked about teams and the need that we need to train people to work in teams, but nobody knows how to do it, and that people aren't doing it. You know, in our experiences, you try and have some interprofessional collaboration and so on, and people go out into the system and they can't do what we've taught them because we teach them something that's removed from the system, and we're not actually working on changing the system. And we have to drive that, I think, from a training point of view in order to make that change. I mean, one of the other big things in the Lancet Commission was around training change agents. How do we train people to be change agents? We've got to think very differently about how we go about educating people in order to enable them to be change agents and to transform the system. And as long as we keep people in the old model of training, we're going to continue with the same problem.
That's a problem we faced in COVID, because a lot of people were not trained, for example, to move from certain specialties to support the team in intensive care unit and you know, an acute unit. We faced that certainly during the pandemic. Did we learn any lesson? I'm not really sure, but I'm optimistic anyway. I'm sure one day we will look at these in more details.
Yeah, thank you very much. We took already 10 minutes longer than planned, but I think we just had a great discussion. Is there maybe some other point you would like to say at the end, or something we missed today, an important topic or issue? Otherwise, we said always that we will stay for half an hour longer, so 20 more minutes to have an informal discussion now, but maybe you have a final point to say.
I mean, to me, my final point is that there are a lot of good examples around the world of fully integrated primary care model as the first contact with the health system, you know, with gatekeeping function, etc., serving the community effectively, which could really highlight and use, you know, for people to look at. You know, it's not impossible, even in countries with middle and low income. They can do that. It's not difficult. It's simply to encourage health workers, whether doctor, nurses, community health worker, etc., to move into this specialty. They need to appreciate how great it is and how fantastic in providing services to the people according to their needs.
You thank you.
Yeah,
Ian, maybe?
Yeah, I mean, I don't think I've much to add, except, I mean, you know, the more that we are putting primary care into our training, the more that we are saying, you know, this is what we believe in. This is the direction we want to go in. And as long as we are saying to people, go and do it, but you know, we're not going to prepare you to do it. We're not going to emphasize it in our training. And the same, you can say that about, you know, the rural aspect as well. If you are not including rural in your training, you know, you're not going to make the impact. So, and as Salman said, there are many good examples around the world of how places have transformed their training and what they are doing. There's some excellent examples of schools in the Philippines, for example, who've completely reoriented the way they are doing training and can show the impact of how they've retained people in the services in the communities that they are serving because of the way that they are training differently.
Absolutely. Thank you.
Yeah, no, thank you very much. Then I would like to close the official part of our session. So thank you really a lot, Salman, and thank you really a lot, Ian. I think this was really an exciting discussion today.